Good morning, everybody. Hello. Hello. Let's settle in, crowd, settle in. All of a sudden, I no longer hate the microphone. I'm feeling very powerful. I might sing a song. Don't laugh. Okay. So it's my pleasure to introduce our own Carley Zeal, who grew up in Monroe, Wisconsin, and is a true Badger College Medical School. And we were fortunate enough to have her stay here for her residency. And I'm so happy for her. She is doing a family planning fellowship, and it's all her hard work at WashU, which is a premier program. Her Grand Rounds talk today is one that's near and dear to everybody's heart in this room. And the commitment from this community around family planning is palpable, and it's a very difficult environment requiring nimbleness and creative thinking. How's that, Jenny? Were those the right words? Okay, good. So I'm turning it over to Carley. Let's give her a round of applause.
All right, thank you. And again, I'm Carley Zeal. I'm one of the fourth-year residents here, and my talk is titled Family Planning, the State of Our Great State. So I have no disclosures. So thinking about my topic, there's something everyone knows about me is that I'm probably one of the proudest Badgers in the room. Having done all of my education here and been lucky enough to stay on for my training here, I've recognized that we are really a leader in the field and we have top-notch training. But anytime you think about how great a program is or how great our department is, we always have to be thinking about where are our opportunities for growth. And one place that I see it is in family planning. So what family planning is really comprehensive reproductive health care for women. And it encompasses evidence-based contraception and abortion care. And so what the Family Planning Fellowship and kind of the division of family planning provides is a network of researchers and clinicians that are on the cutting edge of this care. And also provides global health connections and an advocacy component that's a little bit more unique to family planning. The problem with family planning here is that we're really limited by our political environment. So that's kind of what we're going to talk about today. The outline for my talk is first we're going to go through some background and some historical perspective on family planning legislation. Then we're going to review through what our state legislation entails for family planning, what are the current regulations, and what effect does that have on women's health care and economics. Then we're going to turn back to our institution and what are our strengths in family planning and where can we really grow, and then what can we do next. So for some historical context, thinking about family planning in terms of political legislation really came about in the 60s because when birth control became more available for use. So in 1964, the Economic Opportunity Act signed by Lyndon Johnson established that family planning is preventive health care. And then in 1970, the Public Health Services Act was signed by Nixon, and that's what gave us Title X funding for preventive health care and included family planning. And the idea here is that it was thought that family planning and contraception care would help women be more productive in the workforce because they would have better control over their reproduction and be able to be more economically stable. So these programs are really attributed to a decrease in the total fertility rate since the 1970s. There's also been some pretty landmark Supreme Court cases in terms of contraception as well as abortion care. So the one that everybody really knows about was signed in 1973, and that's Roe v. Wade. And that established that abortion is a right for women based under their constitutional right to privacy. But another case that fewer people really pay as much attention to was signed in 1992. And that was the Planned Parenthood v. Casey case that upheld that abortion should be protected. However, it said that certain state regulations on abortion were permissible as long as they don't cause undue burden to the woman seeking care. So that is really up for interpretation. And what kind of came from allowing these different regulations is what we all call TRAP laws. And these are targeted regulations of abortion providers. What they do is single out the medical practices of doctors who provide abortion and impose on them requirements that are different and more burdensome than imposed on other medical practices. And what we've seen here is kind of they slowly started to get passed in the 90s, and then what we've seen is an explosion of the number of TRAP laws that are written nationwide. So from 2011 to 2016, 334 abortion restrictions were enacted nationwide, which constitutes 30% of the total abortion restrictions that have been written since 1973. So it's kind of a huge explosion. So what are these different types of regulations? So some of those are physician and facility requirements, so things that you've heard of like an ambulatory surgical center, medical abortion restrictions, gestational age limits, state mandated counseling, waiting periods, parental consents, and different requirements for disposal of fetal remains. So how does Wisconsin measure up in terms of TRAP laws and abortion regulations? Wisconsin receives an F, of course, from the pro-choice perspective. This is a grade that's assigned by the National Abortion Federation and NARAL Pro-Choice America. So they publish a report each year called Who Decides? And they give a grade to every state for their abortion regulations. And that grade is based on the state of the state legislature, abortion care policies, family planning policies, so access to contraception and coverage of contraception, and then other important access policies. And Wisconsin has been an F for many years. I think I've been looking at these reports since around 2006, and I think the highest I've ever seen Wisconsin get was a D. So let's start off with what are the good things in Wisconsin to kind of review what types of regulations are enacted in Wisconsin. The things that are good is that we do have insurance coverage for contraception. There's guaranteed equitable coverage of contraceptives in Wisconsin through your private insurance. There's also access to contraception for low-income women, so you may have heard of the Wisconsin Family Planning Waiver. This increased coverage of Medicaid-funded family planning services and coverage of emergency contraception for women. And the thing that's actually particularly good is that they have written this in as a state plan amendment as opposed to needing it to be approved in the budget each year. There's also improved access to emergency contraception in Wisconsin. And then there are clinic protections. So what that means is that women seeking reproductive health care and or clinic personnel cannot be subject to blockades, harassment, and or violence. It's illegal and you can call the police to protect you as you're walking into the Planned Parenthood clinic. So the downside of this is there are plenty of opportunities for growth in terms of family planning regulation in Wisconsin. There are a few pieces of legislation that are on the Wisconsin state law books but are unenforceable. They've been ruled unconstitutional. So there still is a law in our law books that prohibits all abortions. Anytime from conception to delivery, an abortion is illegal under this law. It can't be enforced because of Roe v. Wade, but it's still available. So if there were any problems with overturning Roe v. Wade, and I think a lot of people get somewhat worried about that with the Supreme Court, but it's here. There's also prohibition of partial birth abortion, which has been found unconstitutional based on the vague language of the law. So there's also a national law that prohibits this partial birth abortion, but the language in the Wisconsin law as well as in the Illinois laws are too vague, so it could actually prohibit anything after like 13 weeks. There's also laws for admitting privileges in Wisconsin for any abortion providers needing admitting privileges to a local hospital in order to perform abortions. Just recently, this was ruled unconstitutional in the Whole Women's Health versus Hellerstedt Supreme Court decision. So what are the abortion laws in Wisconsin that are actually enacted? There is an abortion prohibited after viability. This is generally considered 24 weeks gestation. However, it's defined as the time when a physician believes, based on the case, that there's reasonable likelihood of sustained survival of the fetus outside of the womb. And so it makes delivery after that gestation a Class 1 felony for the provider, and you can receive up to $10,000 in fines and or 3.5 years in prison. There's an exception for maternal health. However, if you are delivering after 24 weeks for maternal health, you have to deliver in a mode that is most likely to allow survival of the fetus. So a lot of people would consider that a C-section, often a classical C-section. Similarly, there's a protection of an unborn child capable of feeling pain law. And so what this says is that you may not perform an abortion or induce a labor when the fetus is considered to be able to feel pain, which is defined as 20 weeks post-fertilization. It's not really based on any scientific data, but regardless, it's here, and we cannot induce abortion after that. So there is also a medical exception, but again, you must deliver in a way that is most likely to allow survival. And again, class 1 felony. The next one is parental consent for minors. So a parent or guardian, legal custodian, or adult family member must provide consent for any minor who is seeking an abortion. There are exceptions for medical emergency, rape, and incest. Rape or incest actually has to be reported to authorities in order for that to allow for an exception. There's also an exception if the minor is deemed well-informed enough to make an abortion decision, and that's something that's deemed by the court system. And just to give you an idea of how frequently this parental consent is waived, in 2014, there were 196 abortions provided to minors in Wisconsin, and 15 were allowed a parental consent waiver. The list keeps going, so bear with me. There's also an informed consent law and a 24-hour waiting period. So what the law says is that once this mandated informed consent is completed, you must wait 24 hours after that before you can provide an abortion. It states that the physician who is to perform the abortion must assure that the woman's decision is free from coercion through a private conversation with the woman. It doesn't exactly state that the physician has to do that at the before the 24-hour waiting period, but a lot of people interpret it that way. There is an exception for rape or incest. Again, it has to be reported to authorities, and the waiting period can go down to 2 hours if in the cases of incest. Some of the things that I thought were particularly egregious, the right is a list of all of the things that are required in your informed consent by the state, but some of the ones that are more egregious to me are boldened. So you have to inform the woman the probability of survival of the fetus at the current gestation. You have to give them probable anatomical and physical characteristics of the, quote, unborn child at that gestation. They have to be informed of the benefits that are available to them to assist with prenatal care and with their delivery costs. And they have to be informed that the father is liable for support of the infant, even if he is offered to pay for an abortion. Some other things that are required by Wisconsin law is an ultrasound requirement. This is really common in a lot of states, although it does say that women do not have to review the results of the ultrasound. There's also a lot of coverage limitations on abortion. Coverage of abortion is prohibited under health plans that are sold under the federal exchange in the state. There's also reporting statistics that have to be given in at the end of January of every year. So some of those statistics are whether the patient was a minor or not, the gestational age, and they actually have to report the likelihood that the fetus was able to feel pain at time of the procedure. There's also public funds for abortion are prohibited except for in the case of Hyde exception. So the Hyde Amendment established that medical emergency or threat to maternal life, rape, or incest are cases in which government funding could be used for abortion services. There's also another law that prohibits funding of abortions and actually affects more of family planning services. And what it says is that the Department of Health Services can apply for Title X funding. However, those funds have to preferentially go to the Wisconsin Well Women Program, which is good in its own right. However, they can then only go to preventive clinics that provide other health services. They may not go to clinics that provide abortion, have affiliates who perform abortion, and they may not make referrals for abortion services. So what this does is actually gives Title X funding to places like the Women Care Clinic, which is actually a crisis pregnancy center and doesn't actually provide unbiased counseling to women with unplanned pregnancies. There's limitations on use of fetal tissue. The fetal tissue laws in Wisconsin were originally written to prohibit interstate exchange of fetal tissue, but in the amendment process before it was actually signed, it ended up affecting any use of fetal tissue. You cannot use fetal tissue for anything, research, regardless, anything. There's also a law that states that it's meant to protect hospitals and medical providers, and what it says is that they're not required to participate in abortion. And it may sound okay, but what happens, and we've seen it happen here before, is that a woman comes in with a complication from an abortion and it may not yet be complete, and they, under this law, claim that they do not want to participate in her care because it would require completion of her abortion. There's also some new proposed legislation, one of which is directly affecting us. So it's meant to, what it says is that employees of the University of Wisconsin Hospital and Clinics or the University of Wisconsin system may not perform abortions except in the hospital, so those are for HIDE exceptions. They may not receive training in abortion or provide training in the performance of abortion within the scope of their employment. UW also may not extend liability coverage to these providers if they choose to provide abortion services outside of their employment. So this is not yet on the floor yet. It's not been given a hearing date on the floor in the state legislature, but it is proposed and it's something that's really concerning for all of us. However, there are some people on our side. Representative Lisa Subeck proposed a decriminalization of abortion in Wisconsin law that would bring us in line with Roe v. Wade and basically overturn the current abortion legislation that says we could not. It's been proposed in the past and hasn't really gotten anywhere. So the next kind of question about all of these laws, there's this laundry list, is that how do those actually affect our patients and our provision of care? So we kind of think of this in two realms in terms of access to contraception and then access to abortion. And how does that affect unintended pregnancy rates and then public health outcomes and socioeconomic status of women, and then same kind of thoughts of public health outcomes and neonatal outcomes for abortion access. So in order to understand this, we need to understand the problem of unintended pregnancy. This is a map from the Guttmacher Institute of unintended pregnancy rates in 2010. And you can see where Wisconsin lies on here. We are not the worst state, but we're definitely not the best. We rank in the lower of the states in terms of unintended pregnancy rates, around 50 per thousand women aged 15 to 44. And so the next kind of question is there anything that we can do that's going to actually change unintended pregnancy rates? And what we see is that access to contraception and use of contraception reduces your rates of unintended pregnancy. So the right pie here is unintended pregnancies in the US in 2010. And you can see that only 5% of those happened in women who were consistently using contraception. So if we can get women to use contraception consistently, we can reduce their rates of unintended pregnancy. Another way of describing this is a study that's very near and dear to my heart from my future institution is the Contraceptive Choice Project. So this project is completed at Washington University. They provided free contraception to a cohort of just under 10,000 women or adolescents in St. Louis. They compared this cohort to a similar cohort in Kansas City and then in non-metropolitan Missouri. They analyzed abortion rates, repeat abortion rates, as well as teenage births. And what they found was a significant reduction in abortion rates, repeat abortion rates that were less than half the national average, and teen birth rates that were down to 6.3 per thousand versus 34.1 per thousand nationally. So a huge reduction. And their conclusion from this is that access to effective contraception reduces unintended pregnancy rates. But why is unintended pregnancy really a problem? So unintended pregnancy has been linked to poor birth outcomes. So the Institute of Medicine has reported that unintended pregnancies are more likely to have shorter birth spacing, worse birth outcomes, delayed prenatal care, and decreased breastfeeding. There's also this link to maternal mortality with high-risk pregnancies. And so when we look at maternal mortality and unintended pregnancy, a lot of this data comes from developing nations. And what they find is that when there is access to contraception, you make a difference in terms of maternal mortality when you can reduce high-risk births. And those are births that have short intervals between births, women with high parity, extremes of age, and women with maternal medical comorbidities. And what they found is that when you review data systems from this study had over 200 developing nations, those countries that had higher modern contraceptive prevalence rates had largest reductions in those high-risk births. So providing contraception can reduce high-risk births and help to contribute to reducing maternal mortality. There's also a financial cost to unintended pregnancies. In 2010, there were almost 17,000 unplanned pregnancies in Wisconsin alone that were publicly funded, and it amounted to over $300 million spent on unintended pregnancies, 92 million of which was state dollars. It's estimated that the cost of unintended pregnancy in the US government is $11 billion annually. And it's estimated that for every $1 that we spend on contraception, we can save $7 for unplanned pregnancies. So outside of just government costs of unintended pregnancies, there's socioeconomic impacts on our patients themselves. So the Institute of Medicine also has reported that women with unintended pregnancies have decreased educational attainment and increased economic hardship. And it's said that unintended pregnancy is often an inciting event causing women to transition into poverty. And a recent policy analysis that went across states evaluated contraception access and coverage policies between states. They then evaluated women's poverty rates, and what they found was that early access to birth control reduced the probability of a woman living in poverty. So access to birth control before age 20 reduced their rates of poverty, living in poverty. And that was regardless of their educational attainment, their employment status, or their household composition. There's also some public health impacts to abortion services. So we understand that contraception is a fairly accepted thing, especially amongst those in our field. But abortion is necessary because we can't prevent every single pregnancy. And so abortion access has been linked to having abortion access, especially looking at developing nations, has been linked to reduced abortion-related mortality without increasing numbers of abortions. And it's been displayed in several different countries. So Romania is a good example, Bangladesh, Nepal, Mexico, more specifically Mexico City. As we watch people change their abortion restrictions, we see changes in terms of maternal health. And so Romania has been a really good example because they've gone back and forth in terms of abortion restrictions. Before the 1980s, there were very few restrictions on abortion access in Romania. And then a new legislature took over in the 80s and enacted several abortion restrictions. And what they found was an increase in abortion-related mortality for women, up to 148 per 100,000 in 1989, which is a really striking number for a procedure that we all consider very safe. However, in the 90s, a lot of those restrictions were lifted, and what they found was a steady decline in abortion-related mortality, down to 5 per 100,000 in 2006. And then looking back at the US, a lot of times it's hard to establish things with maternal mortality in the US because we have relatively low maternal mortality. However, we did see a big change in the care of women after Roe v. Wade was passed. Gone were the days of ICU wards of women with septic abortions and post-abortion complications. It's something that some of the people that we train under remember and understand, but it's something the rest of the residents and I have never experienced. However, from 2000 to 2014, the US has seen more than doubling of our maternal mortality rate, from 9.8 to 21.5 per 100,000. And so what we've seen here, and there's not a causal relationship, but what we've seen is that states with lower abortion restrictions, for example, California, have not seen this increase. California has continued to see a decrease in maternal mortality rates from 2003 to 2014. At the same time, Texas, that is one of the most well-known states for high levels of abortion restriction, has had highest rates of maternal mortality at 35.8 per 100,000. So there's also been some data looking at some relationship between abortion access regulation and neonatal outcomes. So policy analysis by Wallace et al., published in 2016, looked at a relationship between reproductive rights and birth outcomes. And what they did was assigned scores for reproductive rights by states, higher scores for states that are less restrictive. They then compared preterm birth and low birth weight rates between the states and controlled for maternal age, race, education, insurance, and state level poverty. And what they found is that states with higher restrictions had a 13 to 15% increased odds of preterm birth and a 6 to 9% increased odds of low birth weight. So where are we with all of this now? From then to now, abortion legislation started off with agreeing that contraception could be helpful to women, keep them in the workforce, give them economic stability, and we should cover contraception for women. We then fought this fight of keeping abortion access legal and safe for women. But what's happened is it's slowly been chipped away, and now we're back fighting for basic healthcare rights for women. So let's go back to UW. What does UW do in family planning, and what are our strengths? So we definitely do a great job, especially considering all of those regulations that I just reviewed. So the strengths in our program are that we have excellent abortion training. It's something that a lot of people were surprised about how much experience I had in abortion care when I interviewed it in other areas of the country. So I think it's something we should be proud of that we provide for our residents. We also provide a full range of contraception, including post-placental LARC programs that a lot of other programs are not able to provide. And I want to thank all of you for getting that started and supporting it. There's also great miscarriage management. So we've coupled with our emergency medicine providers and helped to make miscarriage management more efficient and easier for women by one small thing is providing MVAs in the emergency room. But there certainly is room for us to grow. So things that we can kind of focus on next are collecting data with our family planning interventions and being able to share our information with other parts of the country and get better ideas for what are the best ways for us to care for our patients. We can continue to build partnerships both within our department and interdisciplinarily. And then we can work on training physician advocates because as you can see, we need people out there to tell people why this is important. So what can we do? What is this advocacy thing? So advocacy is defined as action by a physician to promote those social, economic, educational, and political changes that ameliorate suffering and threats to human health and well-being that he or she identifies through his or her professional work and expertise. And so it's a really kind of confusing thing. A lot of people don't understand how to be an advocate, but it's been increasingly recognized as something that's important in OB-GYN residency training and actually is one of our CREOG objectives. So how do we do in terms of physician advocacy? Physicians are in a unique position to be advocates, especially in the political realm, because we're seen as experts in the field. And especially in a time when healthcare is so hotly debated, people want to hear from physicians and what are our experiences and what's important to our patients. However, most physicians do endorse advocacy, but few of us actually engage in advocacy. It's been said that voting doctors vote less often than other professions, and even the public at large. So there's lots of ideas, but there's little evidence as to why physicians don't get involved in advocacy. So it goes all the way back to thinking about medical school admissions. Are medical school admissions focusing too much on academic involvement and less on civic engagement? Residency training it's very time intensive. It's somewhat isolating. It's hard for residents to really get involved in advocacy. Advocacy is also this very unfamiliar field for physicians. We're used to places where we make decisions quickly, we're the leaders in our field, we get automatic feedback to what we're doing, but being an advocate is much more nebulous. We also lead busy clinical lives, and all of us can relate to how busy our lives can get. We're also trained to keep our opinions to ourselves and keep them separate from our patient care. So it's hard for us to navigate this field of understanding how do I state my opinion without imposing it on my patients. But what I'm here to tell you is there's lots of different ways that you can get involved as an advocate. There's lots of forms of advocacy. The first form is something that we probably do every day, and that's being a patient advocate. So at the individual patient level, helping your patients access the care that they need. You can be a physician advocate on your own by calling policymakers. You can be a liaison to the media, so things like writing op-eds. And you can be a health educator, which I know some people in our department have done, putting on education programs for people in the community. You can also be an advocate in terms of practice management. So practice management is how you determine resource allocation, how you have practice protocols, so making sure that all of your practice protocols are evidence-based and really up to date. And then providing patient education resources, so you can be the person that reviews patient education resources and make sure that they're most up to date. Can also be an advocate at the hospital or institution level, so building interdisciplinary relationships, things like building relationships with our anesthesia colleagues to make sure that they're providing the most efficient care to our patients that need procedures, and building relationships with our emergency medicine colleagues so we can provide those MBAs in the emergency room, or helping them to understand providing emergency contraception. But we can also be advocates through society affiliations, things like the American Medical Association, Wisconsin Medical Society, ACOG, the Wisconsin Alliance for Women's Health. All of these things help you to become part of a larger voice, and it's a powerful voice because it's a voice of physicians. And so these organizations help organize things like lobby days, petitions, media campaigns that we wouldn't otherwise be able to organize on our own because of our busy clinical lives. And let me just give a little plug for Wisconsin Doctor Day, which is March 29th next week. So anybody that can get involved really should. And one thing in terms of society affiliations that I've been able to do and have been very lucky to get involved in is the ACOG Advocacy Initiative, the Congressional Leadership Conference. So I've been able to participate in this every year in residency. I've been super lucky to do that. And what you do is you go for a few days and you partner with the OB-GYN Political Action Committee, and they pick out certain pieces of legislation that affect women's health care. And then you learn about those pieces of legislation, how they affect your care, and then how you can talk to legislators about these pieces of legislation. You then, on the last day, have appointments with your state legislators, and you lobby for these pieces of legislation in looking for supporting women's health care. And so the center picture here is actually a list of things that have come out of the Congressional Leadership Conference, things that they've supported or tried to not get passed, and that have actually been successes. So what about family planning advocacy? What can we do for family planning specific advocacy? So things that you can do kind of within our department are, first, updates on legislation. There's a lot of data that shows that some physicians are fairly familiar with legislation that affects family planning, but when you call in clinics, there's a study where they called in to maternal fetal medicine clinics, and staff are often uninformed regarding legislation on family planning and abortion care, a lot of times thinking that it was even more limited than it actually is. So having these kinds of updates on what do the laws actually say and how can we help our patients access the care that they need is important. We also can streamline our referral system. I think here we do a great job of streamlining people that are looking to access abortion services to Planned Parenthood, partly because it's the only place where they can do that here. But for those women who don't meet gestational age limits and things, we have to streamline the referrals to other places where they can get the care that they need. We also need to help them with financial support. There's actually, if you contact ACOG at resources@acog.org, they can help you with what's available in your state or in your area for financial services for women seeking family planning care. There's also a lot to be said for having supportive department leaders for family planning, and I think that we should thank our department leaders, Dr. Bennett for training all of us and being so committed to family planning services, Drs. Hartenbach and Dr. Rice for helping to build our Ryan residency program and really supporting it and keeping it going. But some of the things that you get from having a supportive department is being able to keep updates of the effect of legislation on our practices. So being able to have someone here to talk about what's a new piece of legislation, how does it affect us, and how are we going to still provide the best care for our patients. We can also connect the different divisions of OB-GYN care, so things like connecting maternal fetal medicine and REI with family planning. So when you have those patients that have miscarriages or have lethal fetal anomalies identified, they can have both a consult with MFM or REI as well as family planning, so they can make an informed decision about where they want to go next. You also can have an environment of supporting family planning research. So why this matters is family planning is not exactly a lucrative field for the department. So the way that a lot of departments are able to support their family planning is through research grants. And so having a department that supports you doing family planning research can really supplement income for the family planning division and help it grow. You also can build a family planning staff when you have supportive environments and supportive departments, so that you can assure that at any time there's a family planning provider available that could give whatever procedure or do a consult with a woman that has a need. But the next kind of thing that we do in terms of family planning advocacy is training the next generation. So that has been important in terms of ACGME has made it a requirement to have abortion care in residency. The Ryan residency training program has really built up family planning training and helped to support keeping it evidence-based and at the cutting edge of family planning, but also training new advocates for family planning is important. So how do we train physician advocates? It can start in medical school. So helping medical students giving them training in the determinants of health and health production, giving them leadership and social or organizational change. So understanding system-based practices. So some of the things that the medical school has been doing is having medical students do projects in their kind of primary care rotations, understanding system-based practice. But this needs to continue into residency. So continuing our leadership and social organizational change, practicing preventive medicine, which I think we all do every day in our clinics, but also understanding interdisciplinary work and research. So at the institutional level, getting involved in things like quality improvement projects, at the community level, doing community outreach with education and providing care, and then also political advocacy, which I think a lot of us find very challenging. However, the ACGME has also supported training physician advocates, and so they're putting a lot of force behind community-based participatory research, translational research, and community outreach for residents in training. So, in summary, family planning is a uniquely restricted field in terms of OB-GYN care, and it's really restricted by various state legislatures, and Wisconsin is a particularly restrictive state for family planning. Those restrictions hurt women. They result in worse outcomes for maternal side as well as neonatal side, and they also hurt their economic stability. We as OB-GYNs are in a unique position to advocate for women's reproductive health care because we are the ones on the front lines taking care of these women. and we can take the next steps to build a physician advocate workforce to improve the health of our patients. Some references, and thank you. Any questions? So in my experience in political advocacy, actually science-based arguments don't really get that far. When you're actually talking with a legislator, they don't often understand the science behind it, but it's important for us to understand that and be able to translate it so that we can say and give them numbers. The things that really matter to them are really gut-wrenching stories that pull at your heartstrings. Those are effective, and then the economics of it. So if you can prove to them that it's going to save the government money if they follow you, then you're going to get a lot further. Well, it's really hard to say, but it kind of thinking about what are like the economic impacts of our family planning care. I'd really like to partner with Planned Parenthood to understand who are the women that are receiving abortions, and then what are kind of their reasons, what are they using for contraception after that, to think about how we affecting their repeat abortion rates, and then I would really like to get into how does having family planning services stabilize them economically. So is there anything we can do to figure out, are the women who receive abortions at Planned Parenthood, are they more able to reach their goals in terms of careers, education, and be economically stable later in life? Thank you. I would love to. Mm-hmm. So I don't know specifically an abortion care, but I know a lot about kind of the more baseline political environment in Wisconsin. And what we see is Madison and Milwaukee are very much liberal, and it makes sense for abortion care. Those are the places where now are the only places in the state where you can get an elective abortion. And then once you get into more rural areas, it's much more on the conservative end, much more of a pro-life standpoint, anti-choice. Yeah. I really don't understand the kind of tie between those. You would think that someone who doesn't want abortions to happen would also not want, or also want to provide contraception. And that's really kind of where it started in the 60s, is there were a lot, even on the conservative end, Nixon signed the piece of legislation that provided Title X funding. But there's been this kind of shift to be more in line with kind of religious point of views for the conservative side. And that kind of equates to saying that nobody should be having intercourse, which is just not realistic. Mhm. 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 Oh yeah. Oh yes, definitely. My training in lobbying has been to start off with um, some story that's going to pull at their heartstrings, a sad story that will make them want to listen to you. And then the economics is really where the bottom line is, particularly on the conservative end. So just this year, one of the pieces of legislation that we lobbied for at the Congressional Leadership Conference was the American Health Care Act. And what it came down to is they just want to know how much it's going to cost. Unfortunately, the CBO came out like the day before we were lobbying, so it was a little bit of a challenge for them to understand what was the impact of not providing preventive health care. But that's the bottom line. If I were to present something similar to a group of politicians, talking about maternal mortality rates and neonatal outcomes would not be effective. Thank you. Right. I think a really important part of building a family planning program, particularly in areas where it's really hotly debated and frowned upon in the political world, is understanding that family planning providers are reproductive health care providers. And so they continue to provide generalist OB/GYN care, but incorporate family planning into that as an integral part of care of women. Dr. Lawi? Thank you. Dr. Landry? Thank you. It's also interesting when you talk to women in the community, you find that a lot of women don't understand that Planned Parenthood is not just about abortion, and so they don't know that they can just go to Planned Parenthood to get their birth control. Mm-hmm. 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 The defunding of Planned Parenthood is actually, the way that they even state it is really ridiculous, because they're defunding means that you just can't use Medicaid dollars even for preventive services at Planned Parenthood, no matter what. Even though Medicaid dollars are meant to provide healthcare at any viable healthcare provider for preventive health services. So what that says is that certain healthcare providers are not okay, and that sets a very dangerous precedent. Kevin? Mm-hmm. Dr. Anderson? There was also a study at the forum, the North American Forum on Family Planning, a poster that presented that was about centering pregnancy and contraception use, and those women in centering groups were more likely to use LARC devices and were more satisfied with their postpartum contraception. Mm-hmm. So that's also something that's like very hotly debated. There's several states that still have uh, abstinence-only education programs, but it's not something that I looked in specifically for this talk. Yeah. Okay. I think everybody has a good time.